Professor Marco Valgimigli, talking about minimizing adverse hemorrhagic events by transradial access site and systemic implementation of angioX matrix antithrombin.
Thank you. Good morning, everybody. My declaration of interest. Bivalirudin reduces bleeding events as compared to unfractionated heparin with or without GPI. This has been shown by multiple studies, including matrix. But at the same time, it also increases the risk of stent thrombosis. Bivalirudin label allows continuation of the drug after PCI at either low, meaning the 0.25, or the full, the 1.75 regimen. Whether prolonging bivalirudin after PCI mitigates ischemic without increasing bleeding risks is unknown, since we don't have properly powered randomized controlled studies. The objective of the matrix program were also to determine whether the use of bivalirudin during intervention, followed by post-PCI infusion of at least 4 hours, as compared to no post-PCI bivalirudin, reduces net adverse cardiovascular events, NACE, defined as the composite of death, MI, stroke, major bleeding, urgent target vessel revascularization, and stent thrombosis. We also wanted to determine the impact of bivalirudin on each component of the primary endpoint, and as a target population, we selected a broadly inclusive ACS patient population who were undergoing invasive management via randomly assigned radial or femoral access. Here you have a full overview of the matrix program, which is a combination of 3 independent but nested randomized controlled studies. We present at ACC the result of radial versus femoral, and this paper is published. We present at ACC the result of bivalirudin versus unfractionated heparin. This paper is not yet published, and the focus of the presentation this afternoon will be the outcome of prolonging versus not prolonging bivalirudin at the end of PCI. Just to make the point that this study was sponsored by GISE, which is a non-for-profit organization which received grant for the study conduct from the medicine company and Terumo. We recruited in the matrix antithrombin program 7,213 patients, of whom 3,603 were allocated to unfractionated heparin, so 3,610 patients got randomly allocated into the treatment duration program. The post-PCI Bivalirudin regimen was possible to be given at 2 different Bivalirudin regimens. The full PCI dose was allowed, the 1.75 for up to 4 hours, or the reduced dose at 0.25 for at least 6 hours, with the choice of these 2 regimens left at the discretion of the treating physician. At the end of the study, roughly 2/3 of the patients received the reduced regimen and 1/3 of the patients received the full regimen. The primary endpoint, which was again NACE, a combination of ischemic and bleeding endpoint, was observed in 11.9% of patients in the non-post-PCI bivalirudin group and 11% of patients in the post-PCI bivalirudin group, which is a non-significant 9% relative and 0.9% absolute risk difference. When the primary endpoint was subsequently broken down into its component, there was no difference in death, no difference in MI, which dominated the primary endpoint. Stroke was rare and similar. Urgent TVR and stent thrombosis did not formally differ, but the number were slightly disfavoring the prolongation of bivalirudin after PCI. And on the other hand, the incidence of BARC 3 or 5 bleeding events were lower in patients receiving post-PCI bivalirudin infusion. Definite acute stent thrombosis was identical. Definite subacute stent thrombosis was higher in patients receiving post-PCI bivalirudin. Definite or probable stent thrombosis did not differ. Here you have an overview of all bleeding endpoints that were pre-specified. BARC2 was higher in patients receiving post-PCI bivalirudin, but BARC3-5 non-access site related or gasto moderate to severe bleeding complications were lower in patients receiving post-PCI bivalirudin. TIMI major or minor combined did not differ. This is an explorative analysis where the value of each bivalirudin regimen was appraised, And as you see here, just looking at the numbers, we didn't want to apply any formal statistics. Again, this is a very explorative analysis. The choice between the two regimens was not randomized, but explorative analysis, the full regimen was associated to lower ischemic and bleeding events, whereas the opposite was true for the low bivalirudin regimen. So the post-PCI infusion of bivalirudin for at least 4 hours after the intervention did not decrease the composite outcome of ischemic and bleeding events, including stent thrombosis. This finding was consistent across subgroups. Post-PCI bivalirudin was, however, safe and was associated to lower risk of major bleeding according to BARC 3-5 or gastro scales. At explorative analysis, the post-PCI low bivalirudin regimen was associated to higher, whereas the full bivalirudin regimen to lower ischemic and bleeding risk compared to no post-PCI bivalirudin. And this observation can, of course, only be hypothesis generating. The paper will be then published this afternoon in the New England Journal of Medicine.
Questions for Dr. Valgimigli?
Ed Sussman with MedPage today. Is there, from your conclusions, is there any reason why one would extend the infusion rates or just use the standard procedure?
Well, I think the study leaves both options open. There was no safety signal with respect to prolonging bivalirudin, which was, of course, a matter of potential concern, because one hypothesis was that if you prolong bivalirudin, you may mitigate the ischemic risk, but at the same time increase the bleeding complication, and therefore, in a way, vanishing the potential benefit that we have seen previously for bivalirudin versus unfractionated heparin. That was not the case. At the same time, however, I think our study clearly shows that by prolonging bivalirudin, it does not mitigate the risk of acute stent thrombosis. So perhaps the label which is currently available, meaning that both options are open, remains valid. Based on our study results, I would discourage the use of the low regimen after PCI.
Any other questions? Yep.
Could you show one of your slides again?
Microphone there.
Sorry. Could you show one of your slides again, because it wasn't clear on my handout. This was the primary EP NACE slide. In the results.
Yeah, I'm getting there. This one, I guess. This one or the next one?
That one.
Okay, well, if there are other questions come to your mind, I'm sure that our presenters are available just afterwards to address them.